Hey everybody, Amy Haberman here. I'm going to be talking about renal transplant Doppler, specifically for radiologists. The sonographers have been updated with a lot of this information. Hopefully we'll be providing you some better quality images. We'll talk about QC at the end. And I just want to state that this information is explicitly for Baylor and affiliates. And the images that were obtained here are free from Google Images, or they're images from our own studies. So we're going to go over basics of arterial Doppler, transplant, renal artery stenosis in particular when it comes to transplants, our old/current diagnostic parameters, our new diagnostic parameters, quality control, and then we'll touch on contrast enhanced ultrasound. We're going to start with basics of arterial Doppler, and I'm going to talk fast through this because you guys are going to be able to watch this on video, and so if there's anything that you have questions about or need more time to listen to, you can just pause it and rewind it. So I'm going to go through these pretty quickly. When we talk about Doppler, there are three main parameters that we're going to use. Peak systolic velocities are used to estimate the degree of stenosis, and these are obtained within the renal artery. Acceleration times estimate the speed at which the organ is receiving blood. This is a parameter that we measure inside the kidney. And resistive index tells us how resistant to blood flow the organ is. Again, this is obtained within the kidney itself. So this is a pretty typical high quality Doppler image. And so we've got a good grayscale picture. The color box and the color parameters are set appropriately. The sample volume size is small. It should always be less than 50% of the diameter of the vessel. So that sample volume gate or that sample volume size is very small. We're angle corrected. And then the spectral waveform also has pretty decent parameters here. And so the PRF scale is set appropriately, not too much black above or below the waveform itself. The baseline is at an appropriate level. The gain is appropriate so that we can see the peaks well, but we're not getting a lot of white dots in the background. So this is a pretty nice image. Now when we break apart that image, the waveform itself, we have a few things that we need to pay attention to. So the peak systolic and end diastolic, everyone knows. The only thing that I want to bring your attention to is the end diastolic velocity should be obtained at the end of diastole. Sometimes I see sonographers putting that caliper somewhere between when systole ends and diastole ends, and it's not quite appropriate, and so it should be placed right before the peak starts. Now the spectral envelope is the white line that we see. The spectral window is the space under the envelope, and so we're going to talk about that a little bit more in depth when we talk about spectral broadening. But just think of the white dots that you see making up this line as red blood cells. So when the envelope is sharp, you can take a pencil and draw along that white line. That means that the red blood cells are moving pretty uniformly together at a velocity. There's not a lot of variation. It's a pretty clean looking signal, and that means there's not much turbulence. Turbulence would mean that there are a variety of velocities within the vessel itself, but when it's a pretty clear envelope, and a pretty dark spectral window underneath there, that's a very clean waveform. So I'm going to start with acceleration time. So this is the time it takes from the start of systole to generally the peak systolic velocity. So in that top image, you can see where the green arrow is. That's the start of systole. So it's the time it takes to get from the green arrow to the red arrow. Now, sometimes there's actually a change in the velocity before we get to the peak systolic, and that's the picture on the bottom. When there is a change in the slope, which means a change in the velocity, that is called the early systolic peak complex. If that change is present, if there's a clear demarcation between one velocity and the next velocity, there's an angulation there where that red arrow is. That is our early systolic peak complex, and that is where we measure the acceleration time to. So it's from the green arrow to the red arrow. So here are real life examples of acceleration times. In the top image, you can see that there's no change in that slope. So you would measure it from the start of systole to the peak systolic velocity. Pretty simple. However, in the bottom image, we can see a clear demarcation between two different velocities. The slope has changed. Where that change happens is where we measure the acceleration time. And you can tell by looking, if we, on that bottom image, measured from the start of systole to the peak, it would be a much longer acceleration time. That would be abnormal. That would be tardive parvis. However, there is a clear demarcation that early systolic peak complex is visible, and that is where we measure our acceleration time. And here's just another example. I pulled this from the web of incorrect versus correct measurements of acceleration time. Here is an example of a clear tardive parvis waveform. It's a very prolonged acceleration time. They look like little teepees, and you can see on the bottom the difference between a high resistant, normal appearing waveform versus a low resistant, high acceleration time waveform. So the resistive index is sort of a measurement of how much the organ wants blood flow. Is it resistant to blood flow or is it not? Is it starving for blood or is it pushing away blood? So organs that have a lot of blood flow to them, the brain, the liver, the kidneys, they're going to be pretty low resistance. Usually 0.6 to 0.75 are what those organs are. Now, when we talk about vessels that are feeding places like the face or the limbs, those are more high resistant, not quite as important for those to receive blood flow as it would, say, the brain. So the RIs in these vessels are usually higher than 0.7 or 0.75. And then depending on the vessel, if we're talking about, say, an iliac artery or common femoral artery, we have biphasic or triphasic flow. Those RIs are going to be 1. Now, the RI can be helpful a little bit in the setting of kidney evaluation. It loosely correlates to renal function, but as we've learned over time, RI is definitely not something to hang your hat on. So I mentioned spectral broadening a few minutes ago. Spectral broadening means there are echoes within the spectral window. So in a perfectly laminar flow vessel, there would be no echoes in the window. It would be black. If there are echoes underneath there, then that's going to be positive spectral broadening. Sounds easy enough, right? Just wait. So spectral broadening means there's no dark area under the envelope, right? So in a perfect world, we would have blankness, right? Just black. It's empty underneath there. In our world, though, we're going to get something like this. Now, the reason we see stuff like this in a renal transplant is because the vessels are very small. So if you can't make your sample volume small enough to catch the laminar flow within the center of a vessel, so remember the renal artery is only about 4 millimeters. So that means that we need a sample volume less than 2 millimeters, and most machines won't go less than 2 millimeters. So what happens is within the sample volume gate, that 2 millimeter box, we're going to pick up more velocities than we actually want. So it makes it a little bit hard for us using the equipment that we have in our outpatient centers for us to really detect this. So what I'm going to do is look at where that red arrow is. If it looks a little darker under there, we're going to call that normal, okay? In the setting of a tiny renal artery in a transplant, we're going to call that normal. Again, down here on this bottom image, it's faint, but it is slightly darker under there. So we're going to call that no spectral broadening. Now, the textbooks are not going to call that normal, right? But I'm going to show you why we're going to start working on this and why it's important and why we're going to have to be a little more lenient about what we're going to accept as normal and abnormal. So we're going to call positive spectral broadening if we can't separate the envelope from the window. So here's an example. Now this is an artery way out in the cortex, and so we're going to expect to see broadening here. So if you look at that arterial waveform, there's a little bit more white under there than dark. So we would call this spectral broadening. But again, we're only going to talk about spectral broadening when we're looking at the renal artery itself, and I'll tell you why in just a moment. So let's talk about our transplant ultrasounds. So I've updated the transplant scan protocol a little bit. They're going to give you the same pictures that they were before, but we're going to add a few to it. And so the things that are important here are we're going to start measuring the renal pelvis diameter. So we're going to talk about hydronephrosis in a few minutes. But I want you to know that we're going to measure the AP dimension of the pelvis. If there is any urine in there at all, we're going to have the patient void. They're going to come back, and in the standing position, the sonographers are going to re-measure the pelvis AP diameter. In addition to that, We're also going to add power Doppler images. So we have been a little lax with what we're accepting as far as our color pictures, our color perfusion, how well is the kidney perfusing on color Doppler. We're going to start doing power Doppler images, and I've instructed them to make sure that they're decreasing the scale and increasing the gain to make sure that we can really visualize flow out to the cortex. So there's a slight difference between living donors and deceased donors. So when we talk about a living donor, the renal artery is cut and then sewn in to the external iliac artery like an end to side anastomosis. Every once in a while they'll do an end to end with a branch off the iliac, but usually it's a side to end anastomosis. When we have a deceased donor patient, they cut what's called a Carroll patch off of the donor aorta. So a large patch is removed, and luckily if there's more than one renal artery, it can all be removed in block. And so that way they don't have to cut 2 or 3 renal arteries and try to anastomose those on. So ideally you would have a Carroll patch, and then the patch is sewn on. So that way the renal arteries are not touched. So it's sort of a pseudo-anastomosis because you don't actually have stitches in the renal artery itself, which is good. So where do these waveforms come from? The sonographers are going to give you a spectral waveform of the external iliac artery proximal to the allograft. They're going to give you a Doppler at the anastomosis or pseudoanastomosis, a couple of Dopplers along the length of the renal artery, and then they're going to give you some intrarenal arteries, upper, mid, and lower pole. This is where we're going to measure our acceleration times and our resistive indices, and then a Doppler in the renal vein. The second image shows sort of where the interlobar and arcuates meet. So we don't want to go too far out. We don't want to reach the capillary bed because we have a pressure drop there, and that's going to give us some abnormal artifactual numbers. So we want to catch it before it hits the arcuate. So sort of in that interlobar arcuate area is where they should be giving you signals. So we have 4 techniques that we're going to use. We've been using 3, which are grayscale, color Doppler, and spectral Doppler, but now we're going to be adding power Doppler. And you can see in this image that there really is flow all the way to the cortex, and that's important. That's something we should be reporting. Cortical necrosis is certainly something we need to be ruling out on ultrasound, and we just aren't doing it with what we're doing now. So I want to talk about what a normal renal artery morphology looks like. Everyone knows what the peak systolic is doing, but what does the waveform tell us? And that's equally important when we're trying to figure out what's wrong with a kidney. So the first thing to know is there should be forward flow only during the entire cardiac cycle, no reversed flow at all. Now that's different than the external iliac artery. So in this first image, this is a Doppler from the external iliac right before the anastomosis. And you can see that there is flow forward during systole. It goes down and goes underneath the baseline and then pops back up again at mid to end diastole. So it's a triphasic waveform, completely normal for an external iliac artery. However, once we get into the renal artery, it should only have forward flow throughout the whole cycle. It should not touch the baseline, and it certainly should not be reversed. Now, you have to be careful because if the sonographer is Dopplering what they're calling the anastomosis, you have to look at the color image to see, is that exactly the right location? If they're a little too far into the iliac artery, you're gonna see the same waveform. So, for example, the second image is labeled as anastomosis. Is it that she's getting too much of the iliac signal in there, or is it really pathologic? Well, if you look at the third image, the bottom right, she's well into the renal artery and we still have reversal of flow. This is abnormal. This is an RI of 1. We don't really use RIs outside the organ, right? I told you that earlier. But it's important to know that the RI should never be 1. There should not be lack of diastolic flow or reversal of flow in the renal artery. So if you need to think of an RI, it really should be about 0.8 to 0.85 within the renal artery. Now, we don't report that. We don't use that. But if you can't remember, there should always be forward flow think of the RI of the renal artery. It should be 0.8 to 0.85. Even 0.9 is fine as long as there's forward flow. Now, the other thing we need to look at is how wide is the systolic peak. When it's narrowed, that's called a staccato morphology. And so the skinnier it is, the more pathologic it is. And so in that first image on the bottom left, we definitely don't have flow during the whole cardiac cycle, right? Now, this actually isn't a renal artery, but it shows an example. I've seen plenty of renal arteries look like this, and they're pathologic. There's forward flow, and then it stops. And then finally, systole kicks back in, and there's forward flow. So the beginning of systole has a very staccato waveform. It's very, very narrow. And then it picks up a little bit in mid-systole and beyond, and then it disappears. The second image is such a narrow systolic peak, you don't know what the heck's going on. And you can see a little bit of a blip below the baseline. So there is a touch of reversal flow. This is abnormal. This is probably a kidney that's already failed. I just want to touch briefly on AV fistulas. If these are large enough, you can see them on grayscale. They'll look like a cyst, which would be abnormal in a transplant kidney. But when you put color on, they're going to fill in. And so that top image, you can see this sort of hypoechoic, anechoic area is completely filling in with color. And then when you put a Doppler tracing in that, it's going to be very high velocity flow, and it's going to be very low resistant because there's no resistance within the venous bed. And so it's going to be very low resistant but high velocity flow. When they're taking their cines and they're panning through, make sure that you don't see any areas that look abnormal like this. I have a feeling we're missing a lot of these. I don't think I've ever called one of these on an outpatient, but a lot of these biopsies occur either intraoperatively or shortly after transplantation. So I feel like we should be seeing them, but I have a feeling we're missing them. But anyway, if there's anything questionable, definitely send them back to get additional images if you need to. So echogenicity is a tough one. We don't have the liver there as a control like we do when we have native kidneys. So you really need to have experience. It's an eyeball test. I recommend, if you're not comfortable looking at this kidney and going, oh, that looks hyperechoic, Google images, pull articles, look at as many of these as you can, because this can be tough. It's important and it's tough. So I've got your reference image there on the left, so you can see that the pyramids look very dark on the ultrasound image. So the cortex is more hyperechoic. You can see the columns coming down in between the pyramids, and there's a striking difference between the cortex echogenicity and the pyramids. This is hyperechoic. Usually the difference is not that noticeable between the cortex and the pyramids. So here's an example. The picture on the right is more normal. You can kind of make out the pyramids and the columns, but they're not very different. But in that image A on the left, you can see that the kidney is more hyperechoic, and you can make the pyramids out more distinctly. Something else we need to worry about is corticomedullary differentiation loss. So here, you can't really make out very well the difference between the pyramids and the columns, the medulla and the cortex. Something that we often see with loss of differentiation is loss of that sinus fat. You can make out where the collecting system is, but where did the fat go? Okay, so now that we've covered a little bit of the basics, here's what we're dealing with out in the real world. So in a perfect world, our images would be very high quality, high resolution. Sometimes we get pictures like this. Hopefully they're not quite this bad, but they can be tough, right? It depends on the size of the patient, and will the machine allow us to drop our megahertz to penetrate, and other technical factors that go into it. So unfortunately, sometimes this is what we're dealing with. So again, on our color pictures, it would be really nice if we could easily tell if there were two renal arteries, but we don't get that. We aren't getting op notes in the outpatient centers, and the sonographers really have to try to find it themselves. So unfortunately, we have to rely on our machines and our sonographers to identify whether there are two arteries or not. So in a perfect world, all of our machines would have this beautiful bidirectional power Doppler. Unfortunately, our outpatient centers only have unidirectional, the original classic power Doppler on that orange scale. But you can see very clearly that there's flow all the way to the cortex. Unfortunately, what we've been getting are just color Doppler images like this. And so there are some areas that look like there's great perfusion. We're seeing mainly the vessels that are supplying that region, and we're not actually seeing the perfusion itself. And so what about those areas that don't have much color at all? Are those diseased areas? Are those ischemic areas? We don't know. It's a technical problem. So once they give us the spectral Doppler, we're going to get a series of numbers up here, right? You guys have all seen this. What does all that stuff mean? So the things that we're going to care about are peak systolic and end diastolic, the top two numbers, resistive index, and acceleration time. So pulsatility index is not something we use in transplants. It's used in other applications, but not for us. And the acceleration index is a parameter that used to be used. However, the new literature doesn't really support using an acceleration index anymore. Acceleration time is where it's at. Okay, so now we're going to go over our current diagnostic parameters. Why am I here? What is the problem? Well, I got a phone call from the renal transplant surgery team a few months ago, and they expressed concerns over our reporting. And so there are so many of us and so many patients and so many exams being done that there has been a lot of inconsistency with how they're being reported, the numbers that people are using, and what we're recommending. And so this is where all of this stemmed from. So the biggest concern was inconsistency. So on the side of the radiologists, it was variation in our reporting. So there are a lot of variations in the radiologist comfort level with interpreting these exams, varying velocity cutoffs or acceleration or RI cutoffs that people are using, the varying definitions of hydronephrosis, and then varying recommendations or complete lack thereof. When I looked at the studies that were being done, predominantly at Junius, I found variations in the sonographer skill level, right, between the hospital and the outpatient centers, obviously. And then, of course, there's huge variations in the equipment between our hospital machines and our outpatient centers. So, for example, what is hydronephrosis? Really? So in the first image, I think everybody would look at that and go, oh, there's no hydronephrosis. And in the image on the far right, you would look at that and go, oh, there's definitely hydronephrosis. Do you grade it? Do you call it mild, moderate, severe? Okay. What about the middle image? What do you do with that? And this is a post-void image. So what if it looked worse than that and then they voided and it looked more normal? Or what if this is what it looked like before they voided and then it looks the same after they void? What do we do with all that? Well, we're about to fix that. So there's a lot of data out there on what to do with hydronephrosis. So you can see in 1993 they came up with this system, in 2007, 2008, 2014, and there's a 2016 categorization. There's also this that I found on this website where they look at grade 1 pelvic caliectasis, grade 2 major calyces, grade 3 minor calyces, or grade 4 certainly dilation, but now we have cortical thinning. And so there's a lot of different ways to categorize these. What are we going to do? Well, Dr. Martinez gave me this. So when we were discussing all of these things, he said that that's what they use. This is from the literature that they recommend, and this is what they like. And it's not a bad system, right? It looks a lot like what we use for pediatrics, right, when we do neonatal kidneys. And so grade 1 is where urine barely splits the sinus. Grade 2, we see major calyces. Grade 3, minor calyces. And then grade 4 is when we have what they're calling parenchymal compromise, which is cortical thinning. So we demystified hydronephrosis. We've solved that problem. But the real problem comes with the Dopplers. What are we going to do about that? Well, when I did my literature search to see what was new, and I've got to be honest, I hadn't looked at literature since I was a trainee, so I'm a little behind the times. This guy's name kept coming up, Dr. Fernando Pazier. He's at Mayo, Arizona. And he's got numerous publications. He speaks at national meetings. I may have even come across him at one of the SRU meetings. But I didn't really catch on to what he was doing. And so it started in 2017. They did a study where people had abnormal Doppler findings, and they went on to either angio or MRA. And they have worked with the transplant teams and nephrologists and everyone at Mayo and have developed this system. If you Google SRU top 10 lectures or go to this link, he has a fantastic lecture, and all of this is based on his lecture. It's only 20 minutes, but it will tell you pretty much everything you need to know about interpreting a renal transplant, and it's not just Doppler. He covers other topics, hydronephrosis and ATN and rejection and all that kind of stuff. I don't know how in the world he does it in 20 minutes, but it is fantastic. It is the very first lecture in the top 10 lectures of SRU. It's definitely worth watching. I've summarized the things here, but his graphics and everything are so much prettier. He does it way better than I do. So what are Mayo's initial answers? Well, in 2017, they looked at a group of patients who received kidney transplants and had abnormal Dopplers. And so what they did was they looked at all those retrospectively who had gone on to CTA, MRA, or angio. And what they did was they found these what they call major risk factors. And so they looked at velocities greater than 300 centimeters per second. They looked at turbulent flow or spectral broadening within the renal artery. And then TARDIS parvis morphology, which they used a cutoff time of 100 milliseconds. And what they found initially was that the degree of stenosis correlated with the number of risk factors that are present. Initially, they come up with one risk factor is about 33%, two is 90%, and three being 99%. So what are the limitations of us adopting this system? Well, we often see elevated velocities in the renal artery post-operatively, and we always chalk it up to post-op edema. Well, how can we go? Do we need follow-up imaging? And if so, when is the right time interval? Turbulent flow or spectral broadening can be difficult to assess, right, on any challenging patient, especially in the perioperative period. That, coupled with older equipment, small vessels, and imperfect technical settings by the sonographer, all limit whether we're going to call spectral broadening or not. And then what happens when they have two renal arteries? Well, we don't have op notes at the outpatient centers, so did we miss a duplicated renal artery? And then reporting is variable. So all of these things put together can make it difficult for the surgeons and the nephrologists to figure out what to do with this information. So how do we overcome these? Don't worry, we're going to overcome them. So there's really no literature standardizing what a velocity cutoff for the perioperative renal artery is. So we actually started a research project where we're looking at all the renal Dopplers that were performed on transplant patients for the last 2 years. And we're looking at what the velocities are, what the outcome is, and we're trending it with their GFR and their urine output. So hopefully by this time next year, we'll have some hard concrete evidence as to what the numbers are. But this really isn't an issue in the hospital. We're talking more of our outpatient centers. So I updated the scan protocol to include more and improved Doppler images, right? And I've already provided the education to the sonographers on proper machine settings and scanning techniques and things we need to do to improve the quality. And then I've implemented a standardized reporting template based on Mayo criteria with everything built in. They're literally just pick lists. You don't even have to think for yourself. So I put all this stuff together and I presented it to the transplant team. And what did the surgeons say? Yes, they loved it. They definitely wanted to use the updated numbers, and they loved the idea of having a standardized template so that everybody reports the same way. So what are our new numbers? We're going to use a peak systolic velocity within the renal artery up to 300 centimeters per second. And I want to mention, as he mentioned on his video, Dr. Fernando Pazier, that a lot of times the peak systolic, the maximum velocity, is not really at the anastomosis. It's usually in the proximal or mid segment of the artery. And that's why they need to be diligent about getting Dopplers along the length of the artery and not just at the anastomosis and at the hilum. They have to get some within the length of the artery because that might be where the highest velocity is. For our eyes, this doesn't change, but I just wanted to remind you guys that we know 0.65 to 0.75 is stone cold normal. We're going to say 0.6 to 0.64 is the lower limits of normal, and then 0.76 to 0.8 is the upper limits of normal. That's what some literature calls the gray zone because people aren't really sure exactly what to do with that. And then we're going to use an acceleration time now of up to 100 milliseconds, or if the machine is giving it to you in seconds, it's going to be 0.1 seconds. This is our new worksheet for our outpatient centers. It's updated a little bit, not a lot different than what we've been using. I added a renal artery 2 so that in case they do find a second renal artery, they have a place to put it. I've included a place for them to put the AP diameter of the renal pelvis and then the diameter size post-void standing in case they needed that. I've updated the normal values on here. And so they should be filling this out to completion. I've included a little bit more of the history section. I've asked them to fill it out to completion. So I've created the macro for us to start using based on Dr. Fernando Pazier's literature that he published in 2021, where he's developed structured reporting in this sort of setting. And so there's not a lot that you actually need to put in. Renal length is probably about it. Everything in here is a pick list. And then within the pick lists, I've chosen to put in there whether what you're double clicking on is normal or abnormal. And so it really should be quick and easy, hopefully less painful than the TIRADs. And so you should really just double click on these fields in here. When it gets down to the stenosis major risk factors, you just click yes or no. Is there a velocity greater than 300? Yes or no. Is there spectral broadening? Yes or no. Is there tardus parvus? Yes or no. You add those up. When you click on 0, 1, 2, or 3, it will auto-populate your risk of having renal artery stenosis. And then in the impression, same sort of thing. You click on which one it falls into, and then it tells you what the follow-up should be. So here are a few examples. For urothelium, if you visualize it, it is then called thickened. And if you don't visualize it, it's called normal. Collecting system, expected pelvic caliectasis. If there's mild hydro with major calyceal dilation, moderate hydro with major and minor calyceal, and then severe with cortical thinning. Again, these are just pick lists. So Mayo took that information and expanded upon it over the next several years. And so what they did was they published a study of 922 patients retrospectively, and they found that those that had one risk factor had about a less than 5% chance of actually having renal artery stenosis. The intermediate risk was then stratified to about 30% chance. And so those that went on to additional imaging or angio may have had renal artery stenosis, but it wasn't clinically significant. And so the intermediate risk was now defined as 30% chance of having a stenosis, and then they need to clinically correlate, which is listed there, and then MRA can be performed for confirmation, or they can consider a repeat ultrasound in 6 months. And then 3 risk factors puts them at a high chance of having stenosis, and we will recommend an MRA. Last but not least, this is going to be included on the bottom of the templates, and it's a summary of all the other things outside of renal artery stenosis. This is a quick slide on fluid collections. So when we have loss of corticomedullary differentiation, that implies that there's something going on in the kidney itself. And so we can see this in post-transplant lymphoproliferative disorder and rejection. And usually when we have corticomedullary differentiation loss, we also lose sinus fat. So when we have very prominent pyramids, this implies that the kidneys are hyperechoic. This implies an intrinsic renal process such as ATN or rejection. Here are some useful links. These are all included in the bottom of the template. Now we're going to move on to ultrasound quality control. So we have got to be diligent at looking at all aspects of the image and looking at all the images. If a study is not complete or something's incorrect, we have to call the sonographers and let them know. We have to let them know what the problem is and what they can do to fix the problem. Hopefully the patient doesn't have to come back, but if they need to come back, bring them back. I've actually asked sonographers to ask another sonographer to scan the patient, and I hate to do that, but if I don't think they're capable of doing what I need them to do, I have no problem asking another sonographer to do it. Please use the QC note function on Clario for even small technical problems like an improper gain or a scale setting. They need to know what they're doing wrong. And remember, we have a lot of contractors and temporary people coming through, and we need to make sure that we're upholding a high quality standard even when we have temporary techs coming through. And then make sure that we have what we need. So we need to make sure the waveforms are measured correctly, that they're following the entire renal artery, not just giving you one Doppler somewhere in the artery. They're giving you upper, mid, and lower poles. Make sure that the calipers are in the right place. So here's an example of color fail. The first image definitely shows some vessels inside the kidney, but we don't know what the kidney perfusion looks like at all. The second image shows a nice power Doppler image with flow going all the way to the cortex. And I did ask them, I showed them this image, and I asked them that when they see a picture like this, when they put on power Doppler, if the upper and lower poles are not filling in like they are here, they need to take a dedicated picture of the upper pole and a dedicated picture of the lower pole to ensure that there are no areas of infarct. Here's an example of a wimpy, pitiful scale in the first image, and then the second image shows an appropriate scale. We don't want a lot of dead space above and below the waveform. Here's an example of a case of a renal transplant where they've Dopplered it, and then the waveform is down here. The acceleration time is measured correctly. Those are the first two calipers. However, the end-diastolic velocity that they're measuring here is not true diastolic flow, and I'll show you why. So those are very weak, low-level echoes that are above and below the baseline. If this is true diastolic flow, then the intensity, the amount of whiteness to this spectral waveform should equal the systolic intensity. These are very low-level echoes. The systolic is very bright. This shows that this is artifact and not true flow throughout the cardiac cycle. In this image on the right, you can see that the diastolic component intensity equals the systolic component of the waveform, and therefore this is normal arterial flow throughout the cardiac cycle. It's all forward flow. This RI would be, I don't know, maybe 0.8. Now over here in this image, they've measured the RI at 0.75 because they're putting the caliper where the artifact is. But in reality, if they send you this image, there is no diastolic flow. That caliper should have been put on the baseline. You would leave a QC note for the tech, and you would eyeball that or have them go back on the machine and move that caliper down. But you know by looking at this that the RI is 1. Here is another example. This image is labeled as renal vein, as you can see on the upper left corner. However, this is not really venous flow. So if you look at the color image, you can see that the color is red. You can look at the color map and see that red is on the top and blue is on the bottom. So red is tagged as flow towards the transducer. So on the color image, what they're Dopplering is red going towards the transducer. In case you were unclear about the color, you can look at the spectral. And so on our scale, we have positive numbers at the top, negative numbers below. This waveform is above the baseline. In the positive scale, it's a positive Doppler shift. Therefore, it's going towards the transducer. This is the edge of an artery. There's another way that you can tell on this, and that's because there are these white vertical lines at equal spaces in time. And so this is a cardiac looking waveform because they're at regular intervals. And so what we're doing is we're catching the edge of maybe an arterial branch or right at the edge of the vessel. But at any rate, this is going towards a transducer. This is definitely not a vein. Veins don't flow backwards. This is the image I showed earlier of incorrect versus correct acceleration time measurements. So I'm going to touch briefly on contrast enhanced ultrasound. We are doing these at the hospital. but you don't know to recommend one if you don't know how we do them and what they're used for. So carbon dioxide microbubbles are used, and these are just like what we do in an echo bubble study for the heart. There are no contraindications. Initially there were, but we have figured out how to use it safely. So there are no contraindications to giving microbubbles unless the patient has had a contrast-enhanced ultrasound before and they had a reaction to the proteins that they put in the vial. So what we do is we ask them if they have had an allergic reaction to a laxative before. So those polyethylene glycols that are make up the lipid shell that the carbon dioxide bubbles are encased in is also found in some laxatives. So we always ask the patient if you've ever had a reaction to a laxative. They always say no. So far we haven't had any problems. And so this is a great complement to the Doppler studies that we're already doing. So we can add it to the Doppler, which is usually what we do for renal transplants, but it can also be used as a standalone study of the solid organs. And we've been using it a lot since we had this CT contrast shortage. And so the doctors are getting comfortable with using this. So how much does it cost? Well, it's actually only $750 for a full transplant Doppler exam with microbubbles. The vial itself is $112. So adding a vial of microbubbles is actually pretty cheap. So for reference, a CT angio just of the abdomen is going to cost about $3,000. An MRA is about $4,000. And then an angio is about $6,000. And that's just the exam code. That's not all the technical fees that go along with it. So contrast enhanced ultrasound is really cheap. So here's an early case we did. The patient had just rolled into the PACU after getting a kidney transplant. The tech calls and says, I cannot penetrate. I don't know if this is bowel gas or what, but I can't really get these sound waves to penetrate this kidney and my Dopplers look terrible. So what we did was a contrasted study. And so the bubbles will go in and fill in the parenchyma. So in the upper and mid portion of the kidney, you can see there's good perfusion. As it turns out, this kidney, they had some complications during surgery and they wrapped the kidney allograft in a hemostatic material called new knit. It's like a sock they slid over the organ. That's why the regular ultrasound waves couldn't penetrate, but we were able to confirm that there was perfusion based on the study. This is another case that we had. This is a native kidney and they were looking for renal abscess. So when we gave bubbles, you can see that the bubbles are going into the kidney, and not only is there an abscess there in the center, but there are several other abscesses. Now, technically you can't tell the difference between an abscess and an infarct because the bubbles are just contrast, right? So they're just going to go wherever there's blood flow. So you need to know clinically that this patient came in with pyelonephritis. She was not getting better. Her pain was not getting resolved with antibiotics. And so they were worried that she was developing a renal abscess. And so in that setting, we're going to call these renal abscesses. So here's an example of one of our uterine transplants. And you can see on this color Doppler imaging that we can't really confirm that there's good perfusion of the uterine transplant. Here on the contrasted ultrasound, you can see that the myometrium enhances and then works its way centrally. And the dark area in the center is the endometrial cavity. Congratulations, you made it to the last slide. The link at the top is again Dr. Fanana Pazir's lecture. It's about 20 minutes long or so. It's fantastic. The others are just some of the literature that I've cited here. So if you have any questions or anything, please let me know. Otherwise, happy Dopplering!